Thank you for joining us today. My name is Cecil Granalan. I'm one of the senior admissions counselor and also the forensic liaison at the Chicago School of Professional Psychology. It is my great pleasure to welcome you to our Faculty Spotlight Speaker Series event and introduce you to our presenter, Dr. Jason Dana. Dr. Dana recently completed a 24-year career with the Federal Bureau of Prisons, most recently the chief psychologist at the Metropolitan Correctional Center here in Chicago, where he supervised the professional activities in three forensic psychologists, the drug abuse treatment coordinator, the staff psychologist, and the pre-doctoral externship. He also served on the executive staff at the institution, utilizing his professional expertise to assist the warden with the significant decisions regarding the orderly running of the institution. Dr. Dana graduated from Pepperdine University with a PsyD in clinical psychology, began his career with the Federal Bureau of Prisons, and upon completion of his internship, transferred to the Federal Correctional Institution in Phoenix, Arizona, where he worked in a special housing unit with disruptive inmates, providing treatment for chronically mentally ill inmates, conducted crisis intervention services, and served as the mental health liaison for the hostage negotiation team. He recently joined the Chicago School full-time teaching forensic assessment courses, correctional psychology, and violence risk classes. It is my pleasure to welcome Dr. Jason Dana.
Thank you. I appreciate that. I want to welcome all of you as well. After 24 years in prison, it's good to be out and starting to enjoy some of this private sector work. It's a little bit different, but I began my specific forensic career in 2002 when I transferred to the Metropolitan Correctional Center. And up until recently, just prior to my departure from the agency, all of our competency restoration programs had been conducted through our psychiatric hospital prisons. We had 3 different programs there. Recently, the federal government has begun to develop jail-based competency restoration programs. So I thought today I would introduce this concept. It is a newer approach to restoration of competency with several states that are also starting to use it. And so we will be going through reviewing standard restoration competency programs. We'll then talk about what this jail-based restoration program looks like. I'll review some of the literature addressing the jail-based programming, and then present some pros and cons associated with jail-based restoration programs. This is will be fairly consistent with the literature, but also address some of my experiences as both a forensic evaluator and a supervisor of forensics over the years when I was at the Bureau of Prisons. If there are any questions as we go along, obviously it's a group. I think I can handle questions. So if you want to just put on your video when you have a question and get my attention, and I'd be more than happy to attempt to address them as we're moving along.
Hey, Dr. Dana, before you move on, I just wanted to have you switch your presentation view so that way we can see the full slide.
That's not it.
I think it might be up at the top under display settings. Yeah, swap.
That good?
There we go. Perfect.
All right.
Thank you.
So you were all getting a little advance notice of what was coming next. All right. So let's talk about competency to stand trial quickly. The standard for competency to stand trial is established by a federal government court ruling, Dusky v. United States, which occurred in 1960. This asserted that a criminal defendant had to possess 2 specific functional abilities in the here and now: present ability to cooperate with legal counsel and a rational and factual understanding of legal proceedings. The Dusky Standard further established that impairment in either domain must be a consequence of a severe mental disease or defect. And it remains the standard for trial competency in federal and state courts. Now, the statutes on the state levels may vary depending on what specific state you're in. The Illinois standard specifically identifies that an individual must understand the nature and the purpose of the proceedings against him or her and to assist in their defense. And the New Jersey standard states that the individual must understand the crimes being charged and the consequences if convicted. So all of these state standards highlight specific functional abilities that are consistent with what that state desires or identifies as most appropriate to the competency of the defendant. But it also loosely follows that Dusky standard that was established back in 1960. So competency, why is it important? What is it? Why are we even doing this type of work? Competency is a protection of an individual's constitutional rights. The defendant must be competent for legal proceedings against them so that they can accurately and effectively assert these individual rights, understand what it is that they have available to them as part of their defense in order to ensure that the system is fair. In the event that an individual is found to be incompetent, the federal government and all the states have opportunities to hospitalize the individual for restoration. So based on the type of and significance of the impairments that affect their competency, individuals can be mandated for treatment. Most cases, this occurs at a secure hospital setting. The treatment period also varies by jurisdiction. Generally, the initial competency assessment, competency treatment restoration period is between 90 and 120 days. The federal standard is 120 days. States vary. In most cases, treatment can be extended when the clinician providing services indicates that restoration is likely to occur in the foreseeable future. So Jackson v. Indiana in 1972 established that clinicians had the opportunity to inform the courts that continued treatment would likely resolve the restoration issue, and the courts can authorize extensions. Once a person is determined to have been restored to competence, they are returned to trial. This usually occurs through a subsequent evaluation report that is sent to the court, and then a new hearing conducted by the judge to determine whether or not they meet the existing standard. There is a situation where a person could be adjudicated unrestorable. This would usually occur when the treating clinician ultimately decides that their highest level of functioning has been achieved through treatment, though they still do not meet the standard of competence, or they still are demonstrating functional deficits that would impact their ability to competently proceed. In that case, most statutes require a civil commitment proceeding to occur to determine whether or not the individual can be released. There could be additional conditions of release, continued compliance with treatment, meeting with supervisors of release, circumstances that ideally would keep the individual involved with necessary treatment on the community level. So traditional competency programs, competency restoration programs, have been housed in psychiatric facilities. Most states contract with a state psychiatric facility or multiple facilities in order to provide restoration competency restoration programs. The federal government conducts restoration programs, or has up until recently conducted all restoration programs in prison hospitals. And some states have opportunities for occasional outpatient services. In most cases, on the state and the federal level, individuals could be mandated for treatment of restoration either while they were detained on pretrial status or while they were on their home confinement or released to the communities awaiting trial. And this would be the circumstance under which an individual would likely be referred to an outpatient setting. All of the Federal Bureau of Prisons competency assessment programs occur in secure facilities, what we would refer to as outpatient pretrial facilities. A couple of the federal psychiatric hospitals do also provide those services, but in every case, the person is mandated or remanded to the Bureau of Prisons and placed in custody of the Bureau of Prisons for the purposes of conducting the initial evaluation. And so when competency restoration is ordered, it also occurs in a secure facility. So the referral would suggest the nature and the seriousness of the mental illness. The staffing in these hospital settings is multidisciplinary. It is round the clock. So you're dealing with a very large population of multidisciplinary professionals providing mental health treatment and restoration programming specifically. Appropriate care is afforded the defendant with the intent of returning them to trial proceedings. These programs are psychoeducational in nature, in that there are specific aspects of competency that require them to learn the specific roles of individuals should they have problems with rational, factual understanding of this. There's also obviously pharmacological services, psychiatric care that is afforded the individual commiserate to their psychological needs or psychiatric needs. Clinical services are also provided. So this is a very comprehensive multi-department professional program that handles not only the restoration needs of the individual, but any other medical or psychiatric, psychological services that they require for appropriate treatment while they are essentially hospitalized. A final report and routine updates are provided to the court. And research generally concludes that upwards of 81% of defendants in these hospital settings are restored to competency within 90 to 102 days. If continued treatment is likely for restoration, this can continue. On the federal level, restoration treatment can continue so long as the treating clinician determines that the individual will eventually be competent. Oregon, for example, has a 3-year maximum before the court has to determine whether or not they're going to adjudicate the individual as unrestorable. These programs, as you can imagine at this point in time, are relatively limited with regard to bed space, and they are expensive. So Colorado, for example, a 90-day stay in their state hospital for restoration of competency clocks in at $62,000. And there's essentially there's a lack of funding for extending the bed space, though the need for services has continued to expand. Over the course of the last 20 or 30 years, the number of the number of competency evaluations conducted in the United States has doubled from 30 to nearly 65,000 a year. And so utilizing these state hospital beds or prison hospital beds for the purposes of restoration is extremely limited because of the essential lack of bed space. I think it's common knowledge at this point that inpatient psychiatric services nationwide have been cut, in some cases 50, 60, 70% over the last 20 years, as deinstitutionalization has pushed needy, seriously mentally ill individuals into the community without access to reliable or consistent services. So the hospital-based programs are valuable because they send people who need comprehensive services to a facility specifically designed to meet their needs. So for example, when medical doctors deal with cancer patients, they send them to places where they can receive treatment for cancer from cancer specialists. The same is true by placing these individuals in psychiatric hospitals where they can receive this comprehensive service in addition to the restoration programs. Co-occurring, though unrelated, medical and other psychiatric treatment needs that do not directly impact restoration can still be provided. It's not a narrow focus on just restoring them to competency. This may include rehabilitative services and comprehensive discharge treatment planning with identification for resources should they be released into the community. There's specialized experience with pharmacotherapy treatment. All these hospitals are staffed by psychiatric professionals, and there are well-established mechanisms for forced medication should that be determined necessary and appropriate at some point during the individual's hospital stay. So essentially all of the or a good number of the advantages of hospital-based restoration programs directly correlate with the complexity of the services that are rendered, which is also why they're so expensive. So it's not likely that the costs of these services in these psychiatric facilities can be reduced because the system is already set up to provide this complex source of service. So enter these jail-based competency restoration programs. As I just discussed, 60 to 65,000 evaluations occur a year, which means that there is a significant need for competency restoration. Now, all 65,000 of these evaluations don't result in a determination by the court of incompetence. But when you have limited numbers of beds on a state level, any increase in the demand from the criminal justice system impacts the accessibility of these services. Over the last 5 years or so specifically, the delays in hospitalization has left incompetent individuals in jails for extended periods of time. So as I mentioned, the federal government does all of their evaluations on individuals who have been remanded into the custody of the Bureau of Prisons. So even if an individual is out in the community during their legal proceedings, if they were to be evaluated by a Bureau of Prisons forensic psychologist, they would have to essentially be placed in pretrial detention. In the event that an individual is subsequently found incompetent by the courts, they are likely to stay in jail until such time as they are sent to the hospitals. While extended delays in transporting these unfit defendants to hospitals for treatment has been identified by the federal courts in multiple cases as violating the 14th Amendment, the Speedy Trial Act, and due process of the law, delays can still exceed 3, 4, 5 months simply because of a lack of bed space. Recently, the Oregon Advocacy Center to the Ninth Circuit Court of Appeals a case that specifically addressed this, and the Ninth Circuit Court established 7 days for transport as the allowable legal time period, which essentially means that a good number of states, and in some cases the federal government, are in violation of this this mandate because of the time period that it takes to get individuals into hospital-based settings. So in looking for ways to combat this, ways to improve the timeliness of services for competency restoration, several states, and now more recently the federal government, has started to implement jail-based restoration programs. So instead of taking up hospital beds, these individuals remain in pretrial detention in a county jail, in a federal pretrial jail, or some other kind of state correctional location where competency restoration programs have been implemented. The programs eliminate, in some cases, the need for transportation of the mentally ill defendants to state hospitals. So in the case of the pretrial facility here in Chicago that I worked in, conducting these pretrial forensic evaluations, the development of this jail-based competency restoration program would allow for essentially for immediate transfer of the individual from the pretrial evaluation stage into the jail-based competency restoration program, which would also be available to individuals at this same jail. That's this is the first location the federal government is doing this in. But it also specifically holds beds for individuals who require restoration of competency. And so it doesn't take up any of the psychiatric hospital beds that people with severe mental illness who are already, in the case of the federal government, are already incarcerated, also need. So it eliminates this competition for resources, if you will, as the hospital beds are maintained for individuals with severe psychiatric needs, whereas the jail-based competency restoration programs have added beds that allow these competency services to be provided without the same level of intense and comprehensive service. In most cases, they are designed as advanced jail units with increased access to treatment. They, in most cases, attempt to target higher functioning individuals, individuals who, through the course of the pretrial evaluation, have been determined to not necessarily require that comprehensive level of care that you would otherwise expect in a hospital setting. Now, in some cases, statutes have been rewritten on the state levels to accommodate the use of these programs, as the Ninth Circuit specifically found that defendants could not be held in jail for more than 7 days, and that within these 7 days, a transfer to a state hospital or a, quote, treatment center is required by or mandated by law. So some of the statistics from some of the pilot programs, Virginia specifically had a 5-year pilot program where they demonstrated that between 83 and 86% of the cases achieved restoration. They were restored to competency, and that the average length of stay was 77 days. Obviously, a big incentive here in this Virginia program is that the average cost per day for services in their jail-based program was $42, significantly reducing even some of the lowest costs for hospitalization. The program included the forensic evaluation process, intensive psychiatric stabilization opportunities, and a competency restoration program. So you can see that it didn't necessarily offer the full range of services that would occur at a psychiatric facility, but that it did target specific psychiatric medication needs and the specific need for restoration of competency. They also seemed to achieve competency in less time and for a lower cost. Other advantages that the Virginia pilot program identified was elimination of incentives to malinger. They identified this, conceptually, they identified hospitalization to be a more desirable location for housing of these individuals. And so by keeping them in jail-based programs, it disincentivized malingering of incompetency because it would not ultimately result in them being sent to a hospital. And then it rapidly affords the individual an opportunity to rapidly return to court after restoration is achieved. So we're not, in the case of the federal government, we could be transporting a person 3,000 miles from their jurisdiction. And in states, obviously, that distance could be a lot less. But by maintaining them in, offering the treatment in jails close to the jurisdictions, they can much more rapidly return to court after restoration is achieved. The California Liberty Restoration of Competency Program is the California's jail-based program, and it included twice daily one-on-one restoration contacts. So contacts with a mental health professional twice a day in one-on-one levels for restoration of competency services. There were also daily groups offered that were psychoeducational and targeted knowledge-based competency skills. And they were theoretically consistent with the multidisciplinary hospital approach. So there were opportunities for these individuals to receive a higher level of care than they would simply as jail detainees. But they really didn't specifically outline what those multidisciplinary opportunities were. This program identified 85% medication compliance over the course of services. They established a restoration rate of 55% with an average length of stay being 57 days. The remaining individuals, those who were identified as not benefiting from this jail-based program, were eventually sent to inpatient services. Now, this could indicate that this program is being utilized in some ways as ultimately a pre-screening program where restoration services are being provided in this jail environment while the individual is being evaluated to determine whether they are likely to benefit from this environment. And in the event that they aren't, then routing these individuals for inpatient hospital services. So it still reduces the number of beds that are being taken. But to me, it suggests that there may also be some concern over the selection criteria. If an individual is being evaluated forensically and found to be not competent, shouldn't there be some predetermination of the level of care that is necessary for them to be restored? Or are they just sending all individuals rather than identifying the target population as higher functioning? Are they just sending all individuals to these places for initial restoration? The other issue is California indicated that their costs were $222 a day in the jail-based facilities, which led me to question how Virginia achieved such significantly improved restoration rates on obviously a much lower expense. I think what we're running into is the idea that jail-based programs are not standardized. So there's going to be a lot of variability in outcome and cost. As an example of that, Fulton County, Georgia, identified a third of their jail-based patients requiring inpatient mental health services at some point for restoration. Another third were restored, and 1/3 were identified as unrestorable in the jail-based programs, generally due to either intellectual disabilities, which impacted their ability to learn what was necessary, but also through treatment refusal. So we're seeing a very significant, we got from 86% in Virginia to 33% restored. There's limited standardization of the programs, and we're no discussion about which individuals are referred directly to hospitals versus those who start out in a jail-based program. Even with the most expensive programs, there are clear cost advantages, upwards of 50 to 80%, in some cases even higher than that. But in some cases, this high number of referrals to state hospitals suggests that their initial treatment needs are not being adequately evaluated. And we really don't know how rapid that transfer to the hospitals are once the individuals are identified as needing those hospital services. All right, so some potential problems associated with jail-based competency restoration is the limits of care. While, for example, the California program talked about different services that were provided to individuals, it did not address the professional status of the individuals providing the care. It didn't address whether or not the individuals were being seen face-to-face for psychiatric services. It didn't address the level of supervision that was being provided to those who were prescribed medication. And it didn't talk at all about the resources to manage refusal of services. So ultimately, if refusal of services results in you either being found unrestorable or sent to a hospital setting, then the idea that malingering is being reduced by disincentivizing malingering of competency problems, then these issues with regard to refusal of services returns that incentive, right? So while the argument is being made that malingering is reduced because individuals will not be sent to hospitals, ultimately, between 1/3 and almost half of the individuals who were initially starting out at jail-based programs are being sent to hospitals. So it returns this incentive. And in the case of Georgia's program, with 1/3 of those individuals being determined unrestorable because they were refusing services, it seems like these programs might actually ultimately be reinforcing the benefits of malingering mental illness. Another big issue is use of involuntary medication. Now, we have court proceedings that have addressed the need for involuntary medication, specifically for the restoration of competency. But we haven't talked about, but they haven't discussed or addressed involuntary medication for individuals who maybe pose violence risk concerns. So we've placed these individuals in these jail-based restoration programs with legal precedents for use of involuntary medication that may not specifically address the circumstances in which they are being restored for competency. So Washington v. Harper in 1990 was clearly established when a convicted felon could be involuntarily medicated because of a mental illness. What was lost in the Harper case is that the plaintiff in that case was housed in a specialty psychiatric unit already. So they were already outside of the mainstream of the prison population. As a convicted felon, they were already outside of the mainstream prison population and being housed in a specialty psychiatric unit, which may have afforded greater procedural opportunities for the use of involuntary medication at the time. And Washington v. Harper did not address the environment in which this involuntary medication is allowed, and it certainly didn't address pretrial involuntary medication use. Cell, the United States more recently, essentially reaffirmed the Harper requirements and applied it to pretrial defendants. It identified circumstances in which an individual could be force medicated absent that risk of violence, increased risk of violence or harm to other people or damage to prison property. And it incorporated a couple other requirements that were established in other court cases. But it again speaks to the idea of this pretrial defendant being force medicated at a hospital setting. So the environment in which force medication is allowed for pretrial defendants has not been addressed yet. So there still is no legal precedence that addresses what type of involuntary medication opportunities are available in jail-based competency restoration programs, leaving open the interpretation of these cases who have limited applicability to these jails. And it also does not establish the specific resources, staffing, and procedures that are to be utilized. Some have argued that the jails and the jail-based competency restoration programs still maintain that inherently coercive environment of a jail and prison, which can have a negative impact on the perspective of the individual and their willingness to consent to treatment. So we've got a few problems simply based on the idea that these programs are in jails that have yet to be litigated. And the existing court precedents may only loosely apply to these jail-based environments. There's also no clear criteria for designation to a jail-based system. So we hear that Virginia is establishing 83 to 86% competency rates with their jail-based program, and they're doing it at an extremely low cost. But we don't have the criteria that they used for placing these individuals in a jail-based program. Because the system is already overcrowded, and when you look at the fact that California sent 45% of their jail-based defendants, ultimately sent them to hospitals, and Fulton County in Georgia referred 33% of them. Are there loose criteria that allow an overcrowded criminal justice system to take liberties in the placement of defendants? Is there a system that is set up to identify the severely mentally ill that should be transported directly to hospitals? Or are there a large number of individuals who are just simply being sent to these jail programs only to delay the ultimate transport to hospitals? So if the idea is to speed up services, but they're sitting in jail-based programs before they are being sent for appropriate services, have these jail-based programs serve that purpose. This may also reduce the referral of non-dangerous defendants to outpatient services. So if there's an option to send a person who's being detained in a jail for pretrial services, if there's an option for them to be sent to an outpatient service, does this restoration program disincentivize the use of the outpatient services? Most states have criteria for outpatient restoration programs. So those are already in existence, but are we reducing the use of those simply because we have now redesignated jail beds as treatment center beds? There's no clear criteria across states regarding the service availability. So there is some literature on what these programs should have in the way of services. But there's no standard agreed upon idea of how closely the services should replicate the hospital settings. And are the differences in the services rendered simply in line with the reduced costs? So talking about the hospitals being expensive because of the services that they provide, are we providing a lower level of treatment to individuals by leaving them in jails that they might otherwise benefit from or require in response to the severity of their mental illness? I think these jail programs also overburden an already taxed mental health treatment resources. We know that with the reduction in community mental health centers, the reduction in state psychiatric facilities and the beds that are available for the severely mentally ill, that the criminal justice system has become almost the default provider of treatment. Cook County Sheriff has come out very clearly, identifying that he runs the largest mental health treatment facility in the state of Illinois. And that's obviously at the Cook County Jail. It doesn't even take into consideration all the severely mentally ill individuals who are already serving prison sentences in Illinois Department of Corrections. So are we simply cutting the same pie into smaller pieces by setting up these jail-based programs? And do the cost savings specifically indicate that there's a lower level of service being rendered? So we cannot blur these boundaries between the criminal justice system, the main role of the criminal justice system, and the needs of the seriously mentally ill. The existing programs don't provide the level of service that is necessary for these individuals, and by deferring more and more of these individuals into the criminal justice system and expecting the criminal justice system to provide a variety of services, we're blurring these boundaries between the two systems and putting more undue pressure on criminal justice correctional facilities of all kinds. So in conclusion, these jail-based treatment programs demonstrate significant cost reductions, 50, 80, sometimes even higher. The rates, the program restoration rates at the highest levels are effective, or indicate that they can be, in some cases, at least effective as hospitals. They may reduce the motivation for malingering, but it really depends on how the system is set up and what delayed incentives for malingering could be inherently a part of those jail-based programs. We know it reduces the impact of travel time for treatment access. 3, 4, 5 months is not uncommon delay for hospital placement of those requiring restoration, despite the district appeals court indicating that 7 days is the maximum amount of time that an individual should wait treatment. It does speed return to the judicial proceedings after restoration, but does it also downgrade the minimum requirements for competency as identified by the jail-based programs? They're highly variable in structure, so we can't really determine what the standard of care is, or we haven't identified what a standard of care is. And there's limited case law directing the use of these programs. And in some cases, they directly contradict existing statutes. Some cases may actually be delayed because they are initially placed in a level of service that is inappropriate for their needs. There's a highly variable criteria for inclusion. So what one standard might result in a person in one state being sent directly to a psychiatric hospital. In another state, it may delay their access to the hospital because there is no inclusionary criteria. And it ultimately perpetuates the underlying problems associated with the reliance on criminal justice system as the default provider of mental health and psychiatric services for the seriously mentally ill. So if one of our goals is to reduce the reliance on the criminal justice and the correctional system for providing services, these jail-based programs have reduced the incentives for use of outpatient services. It redirects or impacts the overall financial services or resources that are available for treating the seriously mentally ill in prisons. And it does nothing for the lack of access to community care, as we see being significantly problematic for individuals in the community. So while there are some obvious benefits, and most of them seem to be related to cost reductions, and that should signal some concern, at least, on the part of states and governments that are moving to these programs without having very clear standards of treatment care. So I will turn over to whomever is still here. Any questions or any comments that you may have about this idea of jail-based services?
I do have a question, Dr. Dana. Is there any jail-based treatment programs for first-time offenders in Illinois?
I don't think Illinois is really looking at the offenses when it comes to jail-based treatment. It has been a recent attempt to expand diversionary programs and establish a mental health court where individuals with mental illnesses who find themselves involved in criminal criminal legal proceedings, in part because of the presence of a mental illness. So we're not talking about a person who's insane, but we're talking about a person whose resources are significantly hampered by the presence of a mental illness, who then finds themselves a part of the criminal justice system in the state of Illinois. There is a move to funnel them into a special mental health court, kind of like the substance abuse courts that exist in some counties and some states. So the Chicago chapter of the National Alliance of Mental Illness here, obviously in Chicago, has been identified as a potential treatment provider for individuals who were diverted from the criminal justice system by virtue of their involvement in these mental health courts. So that's a very, I think, positive move. We know that relatively high levels of functioning can be achieved by individuals who have the requisite services available to them. The problem is the way the system is set up in most places, that treatment is actually provided to the individual once they are incarcerated. And so that high level of or improved level of functioning may be achieved while they are either incarcerated or detained, but the minute they return to the streets, that same level of access to care is not available, and it just repeats the cycle over and over again.
Like a revolving door.
Absolutely, yeah. The spiral continues.